Hello friends, today I'll be discussing myopathies. So myopathies is a very important topic from all exam point of views, and I'll be first starting with this case. Okay, so help out this guy. So this is a 14-year-old boy who has come with the chief complaints of gradually progressive weakness of both the lower limbs, right, and the upper limbs. Okay, so it's a gradually progressive long duration of weakness for 5 years, and he's having difficulty in combing the hair, overhead abduction, and difficulty in walking the staircase, which increases on exercise. So I'll be talking about this particular point later. Increases with exercise, which proximal muscle weaknesses increase with exercise. There are one is a fatiguing weakness, which occurs due to your neuromuscular junction (NMJ) disorders, but this is not what we are discussing, because this is a proximal muscle weakness which is gradually progressive. So this is unlikely to be a neuromuscular junction disorder. So he is having difficulty in combing the hair, means there is proximal muscle weakness. Difficulty in walking stairs implies proximal muscle weakness of the lower limbs, right? We did a general examination and this was normal. On neurological examination, all the cranial nerves were normal. Motor power was 3 by 5 in the upper arm, 4 by 5 in the thigh, and there was atrophy. This is a very important point we'll be discussing later. There's atrophy of biceps, triceps, quadriceps, but here this is calf hypertrophy, tone is hypotonia, and deep tendon reflexes are normal. This is a very important point. And sensory was normal. The plantar was flexor, bladder bowel was normal, waddling gait was positive, and Gower sign was also positive. Okay, so having this clinical picture in mind, with a difficulty in the combing hair, suggesting upper limb proximal muscle weakness with intact reflexes, so normal sensory system, plantar flexor with atrophy, and calf hypertrophy, definitely you think of some muscle dystrophy, right? You think of some muscle dystrophy. Now, to discuss what muscle dystrophy it is, we will proceed on to the next slide. Right now, whenever you have a case of any muscle disorder, right, you usually list the symptoms under two groups, right? One is a positive symptom and the one is a negative symptom. So what are the positive symptoms? Positive symptoms due to increased firing in the muscles. So you can have myalgias, you can have cramps, you can have contractures, or you can have stiffness. This contracture is very typical of Emery Dreifuss muscle dystrophy, right? Prominent elbow contractures, right? And negative symptoms can be weakness, atrophy, or fatigue. Okay. Now, what are the general features of the myopathies? General features of every myopathy is always proximal muscle weakness is there. It's a symmetric muscle weakness, and you get preserved reflexes just like we saw in the previous case. So there was symmetric weakness, there was preserved reflexes, and you have to have a normal sensory system, because definitely it's a myopathy, that means a muscle disorder, so it is only affecting the muscles. So sensory system is preserved, and this contracture is very typical of certain groups of myopathies, that is Emery-Dreifuss myopathies, right? Now, how do you approach these cases? A general approach to these cases is that you can divide them into predominant muscle groups which are affected. So if you find that it's the proximal greater than the distal, as we discussed in the previous case, the DDs are limited. One is the immune myopathies, that is your polymyositis and dermatomyositis. The inclusion body part is a different, inclusion body myositis is a different one, which I'll be discussing later in inclusion body, in the necrotizing myopathies, and all those inclusion body. I'll be taking a different video. In that I will be discussing those myopathies. But mitochondrial myopathies, some mitochondrial myopathies, they definitely present with proximal greater than distal weakness, and this is the major group which actually is the most common groups of myopathies, which you get a lot of questions from also. That is the limb girdle muscle dystrophy, Duchenne's muscular dystrophy, Becker's muscular dystrophy, and so what was the case we discussed? It has a DD of LGMD or Duchenne's muscular dystrophy. I will discuss which type of LGMD and which type whether it is DMD or which type of LGMD I'll be discussing later. But basically, our DD in the previous case, that 14-year-old boy, was will be among these three. Endocrine myopathies, definitely they occur with your hypothyroidism, Cushing syndrome, all these things. Diabetes can cause myopathies, okay? And toxic myopathies due to intake of certain drugs can definitely be a reason. Neck muscle weakness is very very typical in only three diseases. One is the facioscapulohumeral dystrophy, then you have Pompey's disease, and then Duchenne's muscular dystrophy. Facial weakness occurs in myotonic dystrophy, facioscapulohumeral dystrophy, right? As you can see, in myotonic dystrophy, you have a very typical face which is otherwise known as a hatchet face, and you'll have frontal baldness and this temporal hollowing and all these features. Pharyngeal muscle weakness or dysphagia occurs in patients with oculopharyngeal muscle dystrophy and also in myotonic dystrophy. And if you look at ptosis with ophthalmoparesis, it is involvement of the extraocular muscles, occurs, as the name indicates, chronic progressive external ophthalmoplegia. Facioscapulohumeral dystrophy, the name indicates facial muscles, so it is facial weakness. Scapulohumeral, so here it is scapulohumeral and muscle dystrophy. Myotonic dystrophy also involves, along with the face, the extraocular muscles and causes ptosis. And here is oculopharyngeal, so ocular and pharyngeal muscles are involved in OPMD. If you look at scapuloperoneal muscle dystrophies, these are emeridryphus muscle dystrophy, facioscapulohumeral muscle dystrophy, and LGMD2A. So we'll be discussing more about LGMD2A when we discuss LGMDs. Now, this is a very distinct group of disorders which are otherwise known as distal myopathies. We all know that myopathies involve the proximal muscle. There are some myopathies which involve the distal muscles. The distal myopathies are autosomal dominant and autosomal recessive. With a very simple classification I have made. Among the autosomal dominant distal myopathies, some can have upper limb onset, some have a lower limb onset, right? And the predominantly upper limb onset is the Welander myopathy, which has greater than 40 years. Is the predominant age of onset, that is Welander. Lower limb onset can have age of onset greater than 35 years, or it can have an age of onset less than 35 years. The elderly patients of lower limb onset of autosomal dominant distal myopathies are positive for this rimmed vacuoles. And what are the two types? One is the Marcus-Berry-Griggs, which is also very commonly associated with cardiomyopathy, and another one is Wood's myopathy, which also affects the lower limbs. And without rimmed vacuoles, you get a lot of questions on this, is a Lang's myopathy, which is predominantly lower limb onset, associated with no rimmed vacuoles and with an age of onset less than 35 years. In the autosomal recessive group, you have affection of the posterior calf or the anterior thigh. So either it can be posterior or it can be anterior. If it affects the anterior group, definitely you will get foot drop. And when the word foot drop comes to your mind, the only myopathy which can present with foot drop are these two, Nonaka and DMAT, dysphalanopathy. DMAT is a type of dysphalanopathy. This you may remember, may not remember, but definitely remember this Nonaka. Posterior calf affection is definitely a Myopathy, which is a type of dysphalanopathy, or an octaminopathy deficiency. This you may remember, may not remember, but Myopathy you should definitely remember. So Myopathy and Nonaka. Out of this, Nonaka is actually affecting the anterior, the Myopathy is affecting the posterior, right? Now, let's have a look at the hereditary myopathies, the Duchenne's, the limb girdle, FSHD, that is facioscapulohumeral, and reverse oculopharyngeal myotonic dystrophy, and the distal myopathies, which we already discussed. Right? Now, let's have a look at the important points with respect to Duchenne's muscular dystrophy. What are the differences between DMD and BMD? So DMD is basically X-linked recessive. This you have to remember. The mode of inheritance is X-linked recessive. It is associated with a mutation in this gene which is known as a dystrophin, and since it is X-linked recessive, obviously it will be more common in the boys than in the girls, and DMD is more common than the BMD. This we have been learning. We always keep more focus on DMD, so definitely DMD is more common than BMD. And early lower limb proximal symmetric weakness. So the pattern of the weakness is usually the proximal muscle. Okay, these are the proximal, and it will be symmetric, right? So symmetric proximal muscle weakness occurs in Duchenne's muscular dystrophy, and you get calf hypertrophy, which is very very prominent in patients with Duchenne's muscular dystrophy. So in our case, we had calf hypertrophy, we had symmetric weakness, but it was not lower limb early. Okay, the BMD, the onset age of onset was 5 to 15 years. Okay, but yes, this definitely the previous case. If you look at the age of onset, it was 5 years before, so that means he is 14 years of age, and it definitely matches the BMD's age of onset. There is associated mental retardation in patients with BMD. If you look at the cardiac manifestation, you'll get DCM, you'll get heart failure, and therefore you should get a 2D echo in all the patients with Duchenne's muscular dystrophy. And this Gower sign is actually the usage of the the legs, so the thighs, to get up from the sitting position. So you ask the person to get up, the patient to get up from the sitting position, and he will use the support of the thighs to get up from the supine from the sitting position. So that's what is known as Gower sign. And because it is a myopathy, definitely the CK will be increased, and mutation analysis in the peripheral blood, that is the dystrophin mutations, has to be done. And there is some role of glucocorticoids in some clinical trials, it has been shown, so you can try it in patients with DMD. Now, a few words about LGMDs, right? LGMDs are actually divided into two types. One is autosomal dominant, the other one is autosomal recessive. The type 1, the LGMD type 1 is autosomal dominant. 1 is always dominant. 2 is recessive, actually 1 and 2. And 1A is due to mutation in the myotilin. 1B is due to lamin. 1C is due to caveolin 3, and D for D, that is DNA JB6. So actually these two are easy to remember, because 1C is C for C, caveolin 3, D for D, DNA JB6. This you can remember. A is myotilin and B is lamin. Okay, and the very prominent point which is usually asked in the MCQs is that myotilin usually presents with pharyngeal muscle weakness, just like your oculopharyngeal muscle dystrophy. You can have pharyngeal muscle weakness in patients with LGMD1A. This is an MCQ. Okay, if you look at lamin, you get cardiomyopathy and contracture. So cardiomyopathy is also a feature of DMD and BMD. Always try to associate with other myopathies, and then you can remember that. Contractures is very very prominent in Emery Dreifuss. So definitely the DD will be Emery Dreifuss muscle dystrophy. And caveolin 3 is more common in childhood. You also get Gower sign, and you also get exertional cramps. This was what I was talking about. You get exertional cramps, right? So that means on activity you will get some positive symptoms. So cramp is a positive symptom, so you get exertional cramps, just like in our previous patient, right? There was a exercise and there were development of cramps. Now if you look at 1D, you get features of myofibrillar myopathy on biopsy. This you have to remember, myofibrillar myopathy I'll be talking about next, that is myofibrillar myopathies later. So 2A is due to calpain 3, 2B is due to dysferlin, 2C to 2F are very easy to remember. They are gamma, alpha, beta and delta sarcoglycans. So C is gamma, D is alpha, E is beta and F is delta, right? C, D, E, F, gamma, alpha, beta, delta. And the D differential diagnosis will be DMD. And 2J, you may remember, may not, it's not that much important, Titin, and Walker-Warburg is K, and 2M is Fukuyama type of congenital muscle dystrophy. And 2A is due to calpain 3 and 2B dysferlin. These are very, very important, very, very MCQs. Many MCQs have actually come from these. And what is important in 2A is this one, that is winging of scapula. You get winging of scapula in patients with LGMD 2A. And the differential diagnosis in these patients is eosinophilic myositis. You have to remember these 2 points. One is winging of scapula, then is eosinophilic myositis. In 2B, you get a rigid spine, and the DD will be a Miyoshi myopathy. Now, few words about Emery-Dreifuss. Very few questions have come, most due to this prominent contractures which occur in this disease, and the contractures usually affect the upper limb. This is what you need to remember, and it is X-linked. Definitely it will be more common in the males, and humeroperoneal onset, right? That means it affects the arm muscles and the the peroneal muscles, the lateral part of the leg. And there is also cardiomyopathy. There occurs atrial fibrillation and AV block. These are the 2 points which also we found in patients with your LGMD, right? So cardiomyopathy LGMD 1B, which is associated with the cardiomyopathy and contracture, just like the Emery-Dreifuss muscle dystrophy, right? And definitely CK will be increased. And how to diagnose, how to differentiate EDMD from LGMD2B is by the absence of this Emerin staining. So Emery-Dreifuss, is the name has come because of this absence of Emerin staining. And how do you treat these cases? Definitely you treat with a supportive treatment, and definitely if there is cardiomyopathy, you have to go for because the risk of sudden cardiac death is very, very high in these patients, go for a implantable cardioverter defibrillator, right? Now a few words about myotonic dystrophy, that is otherwise known as dystrophia myotonia type 1 and type 2. Now what is so typical about type 1 is that it is more associated with CTG repeats, which you all know from our pathology classes, that is CTG is the repeat which occurs in type 1, and this is a triplet, and this is a quartet repeat which occurs in DM type 2. Okay, and there are no hatchet faces, no AV block, and here it is again proximal greater than distal, whereas in type 1 it is distal greater than the proximal weakness. So 1 is distal greater than proximal, and 2 is proximal greater than distal, right? So this you have to remember. It is autosomal dominant, it has got a hatchet face, there is a frontal baldness, that these features constitute the hatchet face. There is temporal hollowing, there is frontal baldness, and it is an autosomal dominant one. You get a palatal pharyngeal tongue involvement, right? So it can present with dysphagia or dysarthria because of these palatal and pharyngeal and the tongue muscle involvement. You also get this myotonia, which is incomplete relaxation of the muscle. If you do the ECG in these patients, you may get some AV blocks, and these patients may go into heart failure. And you also get posterior subcapsular cataracts, you get testicular atrophy, insulin resistance, esophageal dysmotility. So definitely patients will have infertility, they will have diabetes, and they will have GERD or achalasia also. Few words about facioscapulohumeral dystrophy. Here, as the name indicates, fascio, so early facial involvement, scapular, that is wing of scapula, and you get a polyhill sign, that is involvement of the arm muscles, that is sparing the deltoid um, in this muscle dystrophy. So you get a polyhill sign because the other muscles are involved but the deltoid is spared, so that is why you get a polyhill sign. And Coats disease, the ocular manifestation is its involvement, it is associated with Coats disease. And skin features are telangiectasia. Eye features, Coats disease is also associated with retinal detachment and exudates, right? Now, a few words about oculopharyngeal muscle dystrophy. As the name indicates, you get progressive external ophthalmoplegia ocular, right? There is progressive ptosis, and ptosis is pupillary sparing, definitely, because there's no involvement of the third cranial nerve. So, definitely, it will be pupillary sparing. You only have involvement of the extraocular muscles, so it is pupillary sparing. You get dysphagia because there's pharyngeal muscles, oculopharyngeal, and the CK will be 2 to 3 times raised. But the most characteristic feature in electron microscopy are these 8.5 nanometers tubular filaments, which are very, very characteristic of oculopharyngeal muscle dystrophy. And the MCQ which is asked is this PAPB2 expansion, which occurs in OPMD, right? So thank you very much for your patient hearing, and hope you like this video. And please subscribe to my channel for more updates on myopathies and neuropathies. Actually, the next video I'll be uploading on peripheral neuropathy. So thank you very much for your patient hearing.